Today, we are pleased to welcome Dr. Typhanye Vielka Dyer, a dear colleague and friend of mine. Dr. Dyer is an associate professor in the Department of Epidemiology and Biostatistics at the University of Maryland, College Park. Dr. Dyer is a trained infectious diseases and social epidemiologist and health disparity scholar whose research examines the influence of social, psychological, and behavioral factors on STI and HIV risk in Black populations. Her work examines syndemics, so intersecting psychosocial and structural barriers, as well as including the impact of trauma, poor mental health, and criminal justice involvement on STI HIV outcomes for Black sexual and gender minorities, as well as Black women living with HIV in the DC metro area. Today, she will be presenting on Syndemics and Intersectional Frameworks, application to HIV prevention and treatment in marginalized priority populations. Please, everyone, join me in welcoming Dr. Dyer.
Hello, everyone. In my mind, in the background, I hear the crowd. Thank you so much for that wonderful introduction, Jamila, my sister in the struggle. I've known Jamila for like 10 years now, maybe even 11. So before I get started, first and foremost, this was like my last slide, but I think it should be my first. My first thing is I just want to thank UC San Diego and your CFAR and your HIV Institute for inviting me. Jamila, thank you so much for thinking of little old me when it comes to someone who could have something to offer this wonderful esteemed group of colleagues and staff, faculty, students at UC San Diego and abroad, right? And so thank you so very much. What I'm going to be talking about today are syndemics and intersectional frameworks, application to HIV risk behavior prevention and treatment in marginalized populations. I do want to be very clear. I'm on the East Coast. It's 7 o'clock. So if I look like it's the end of the day, it's because it's the end of the day. All right, let's go ahead and get started. I'm going to share my screen. If everyone can see this, that's great. So this is my talk. It's going to be on syndemics and intersectional frameworks, application to HIV risk and prevention in marginalized priority populations. So what are syndemics? Okay, so this is, my work and what I do. So a syndemic was first proposed by Meryl Singer in the mid-1990s, culminating in a textbook in 2009. This particular framework posits several core concepts. So one is the concept of disease concentration, also disease interaction, but not just their concentration and the way they interact with one another, but also it posits that there are these underlying social forces that really exacerbate the experiences of these disease interactions and the ways that they are concentrated and come together to increase burden of disease in certain populations. So Meryl Singer in 1994 developed a study called the SABA Syndemic. A lot of people who started work in syndemics, they did use the SABA framework. This is a set of closely intertwined and mutually enhancing epidemics. And so these are words that I'm going to be using a lot during this talk. So in this case, for the SABA Syndemic, it was the intersection of substance abuse, violence, and HIV/AIDS, right? And so that's where you get the SABA. These mutually enhancing epidemics are reciprocally influenced and sustained by a larger risk environment. And this broader set of power relations, which are shaped by gender, race, ethnicity, and class. And so I'll get to a little bit more about these broader sets of power relations as they relate to intersectional frameworks as well. These inextricably linked epidemics are synergistically reinforced. And so again, I want to make the distinction between syndemics and comorbidities, right? And a lot of that is analytic, but it's also conceptual. So I'll get into a little bit of that. So these linked epidemics are synergistically reinforced by, again, multiple behavioral, biological, and structural mechanisms So I'll talk a little bit about a little bit more about that as well. And so this takes us away from the behavioral aspects of a lot of what we do in public health and starts to really look at not only biological, behavioral, psychological, but the structural mechanisms that are also in place that sort of keep people in places of oppression, right? So again, syndemics are an aggregation of two or more diseases in a population. And so we're going to talk about how this has expanded some in recent years in terms of the research that I do and some of my colleagues, in which there's some level of positive biological interaction. And by that, I just mean that they're correlated, right? So as the number of diseases or conditions you're exposed to goes up, then so does your risk for HIV and other risks or other STIs and sequelae from them. And these biological interactions exacerbate the negative health effects of any or all of the diseases. So again, the whole is more than the sum of its parts. And that is what a syndemic is, okay? Syndemics tend to develop under conditions of health disparity. These could be poverty, stress, structural violence, incarceration. Again, so not just things that occur at the individual level. So we do know depression, substance abuse, things of that nature, but also poverty, the built environment, environmental stressors that also reinforce these conditions of disparities. And so altogether, they contribute to significant burden of disease in affected populations. And most of these populations are, in fact, underrepresented minority populations, marginalized populations. We do say underserved, but we're trying not to say that anymore, or hard to reach. That's the word. They are underserved, but hard to reach is difficult nowadays. We like to use the term hardly reached in research now around marginalized populations. So again, syndemics are more complex than comorbidities. Syndemics presume that there are interactions between biopsychosocial and structural factors. So again, like I said, the total effect. So when I say that, I'm thinking about how we model syndemics. The total effect exceeds that of the sum of the effects of the individual syndemic factors. So poverty is one thing, stress is one thing, substance abuse is other. The sum of those, the total effect of all three of those is greater than the sum of each individual syndemic factor. They cluster together, they interact with one another. And in addition, the syndemic approaches also take into account social conditions. So not only do we have these biopsychosocial, these things that happen to people, there are also these social conditions, right, that are linked to the biopsychosocial factors, grounded in theory that prioritizes the social and structural determinants of health, right? So we're not just talking about the SDOH as social, we're also talking about structural determinants, right? And what we do is we want to focus on both the individual and community or population, okay? So we move our research from the study of disease beyond just the individual. And we're looking at community level stressors and environmental factors that might influence one's ability, because what we talk about a lot in HIV work is PrEP. Oh, there's PrEP, use PrEP, it's there, go get it, right? But if I'm homeless and don't have any money and ain't got no job, then PrEP, I want to take it, but I also want to eat, right? And so again, we're thinking about the ways that people's lives come together, right? And these may impact their ability to utilize services that are seemingly available, but we know sometimes access is something completely different, right? So these are three frameworks with respect to syndemics. They mean, I don't want to say they mean absolutely nothing. I mean, they're actual illustrations of syndemics. So one thing that I want to be sure that we're clear about is that they co-occur. So the one to the left, the gray one or the black and white one, we have poverty, incarceration, substance abuse, HIV/AIDS, and trauma. They form a syndemic. They co-occur. There are psychosocial factors that co-occur. But when you think about a syndemic, they're more dynamic than comorbidities, okay? Because with disease occurrence, with or without interactions, they're just comorbid or co-infections. You've got HIV and diabetes. All right, you've got HIV and something else, okay. But when they co-occur and they are more dynamic, meaning they're synergistic, these psychosocial factors possess, they're like energy, there's synergy. I think about like something not exploding, but like it's alive, right? There are these moving parts. So in the second illustration, we've got substance abuse, homelessness, HIV infection, and sex work. So it's a syndemic of mutually reinforcing interactions of disease and social conditions. Again, moving to the right, they are reinforcing. So the exposure to these factors is multidimensional. So we have biological influences, behavioral influences, psychosocial and structural influences. So to the right, we've got substance abuse, HIV, STIs, violence and sexual abuse, and mental health. They all reinforce one another and result in excess burden of disease. Intersectional frameworks, okay? So this is very interesting. You can see that the illustrations, they look a little bit like syndemics, right? So you've got all of these multiple things that are intersecting with one another. Analytically, intersectional frameworks consider a collection of factors, that sounds familiar, that affect a social individual in combination rather than considering each factor in isolation. Ding, 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 sounds a little bit like syndemics, a lot a bit different. Conceptually, we're moving to the right, we have our wheel of power and privilege. This is where intersectionality is really special. So intersectionality is an analytic framework that allows us to understand how aspects of a person's, again, we're social and political identities, combine to create modes of discrimination and privilege. See, Syndemics doesn't talk about that part, right? This discrimination and privilege, oppression and empowerment and all of these things. And then we've got our intersecting social positions. These are things like race, class, gender, sexuality, religion, disability. Anything that has an ism, racism, classism, right? Sexism. Those are intersecting social positions. And here we have politics, age, disability, belief, gender, nationality, SES, and race. So these intersecting and overlapping, sounds like syndemic, social identities may be both empowering and oppressive, but what they do, power dynamic to remain in place. Intersectionality is a qualitative analytic framework that was developed by Kimberly Crenshaw in 1989. The 89 and 90s were popping, right? Because we got Kimberly Crenshaw in 89 going, something's going on here. And then we've got Meryl Singer going, there's something going on here with syndemics, right? So it seems like 1,000 years ago. But for those of us who are going on 50, it feels like just yesterday. So what she described was how intersecting positions of power affect those who are most marginalized to create and maintain structural inequality. The marginalized also hold space in multiple intersecting, again, social positions, race, class, gender, sexual identity. Intersectionality, this is where it differs from syndemics, opposes analytic systems that treat each axis of oppression in isolation, as if discrimination against Black women could be expressed as simply misogyny or racism. Sojourner Truth, Ain't I a Woman? I'm not going to get into the whole poem, the whole shebang. But what it kind of harkens back to is this white man opened up a door for a white woman. He was very chivalrous. He opened the door, he helped her out, to think that, and didn't help Sojourner, the Black woman. And she's thinking, ain't I a woman, right? So while I am a woman, I'm also a Black woman, and my Blackness doesn't afford me the same levels of chivalry and care as it would a white woman. So she asks, well, I'm a woman too. Patricia Hill Collins, Black feminist thought, talks about intersectionality, which invites ways of understanding how social inequalities, again, of race, class, gender, sexuality, age, ability, and ethnicity shape one another, right? So Black feminist thought, Black feminism, the feminist movement was wholly white, the civil rights movement was Black, Black women were somewhere in the middle going, where do I fit in, okay? Again, Lisa Bolag, who's my mentor, wrote this paper. Once you've blended the cake, we've all made cake. I don't bake, but I can imagine what it's like. You can take the parts, once you bake the cake, excuse me, you can't take the parts back to the main ingredient. So I am all the time a Black woman. I can't disaggregate my Blackness. Oh, hey y'all, I'm Black today. Hey, I'm a woman. I'm a Black woman. I'm an older Black woman, etc. Right? So I can't disaggregate parts of my social identity. I'm all the time, all of these things at once. So this paper was about Black, gay, and bisexual men's experiences with intersectionality. So one of the criticism, it's a qualitative analytic framework. Critics have characterized the framework as ambiguous and lacking defined goals. It's probably a quantitative scientist who really wants the numbers. And so it's based in standpoint theory. So I've had a colleague say, well, Typhanye, I'm glad you analyzed the data to death, but it's all about self-report and people's perceptions. I'm like, perception is everything. If I walk outside and I feel like somebody discriminated against me because I'm Black, then that's what it is. I don't know what it is, but that's what I thought it was, and that's what it is, and that's how it is. So a lot of people feel it's very subjective and might lead to contradictions, and the inability to identify what we try to do in research is what is the common cause of oppression? So for me, if I feel like, oh, that happened to me because I'm Black, and then someone else said, no, that's because I'm a woman, how do we pull this together? Everybody's got a different perception about what it happened when they were discriminated against, and we really can't get that common cause, right? And so that's some of the criticism around it. Syndemics and intersectionality. So when focusing on marginalized populations, I think both syndemics and intersectionality are critical in understanding systems and experiences of oppression that are associated with poor health outcomes, right? So, we're in public health. A lot of us, we're in medicine, we're clinicians, we're psychologists. We're thinking about mental health, physical, and emotional well-being as well. Ultimately, development of interventions that are targeted to the individual experience, right? So when we know that there's a syndemic, we can say it was the people that fell into these classes. They were high stress, low depression, high stress, high substance use, high this, low something else. We want to target the areas where people are being unduly influenced or unduly exposed to things that are making their lives hard. My work, so anyway, I see it, I see a syndemic as examining what are the co-occurring synergistic conditions that unduly place specific segments of the population at higher risk for HIV and its sequelae. Intersectionality helps us understand the why. Why is it that syndemics occur more frequently in underserved marginalized groups? So you got the what, you got the why. So I feel like we need them both. My work focuses primarily on syndemics. I'm a quantitative researcher. So my work on intersectional stigma, HIV stigma, and HIV among older Black women, intersectionality, in the DC metro area requires that I collaborate with a qualitative scientist. I do. Her name is Dr. Vielka Sangaramurthy. She's a medical anthropologist. She has her MPH in Epi, however. Interestingly enough, she just wrote a paper and it was talking about, is syndemics useful? And I text her and I said, oh, I see Vielka. We've published papers together. She's a great friend of mine. I said, I see you're talking smack about syndemics. And she texted me back and said, I love talking smack about syndemics. And I said, well, okay, that's great. Next time you talk smack about syndemics, can you please cite my work a little bit more so I can get a little kick in my H index? Help me out a little bit here, right? So we kind of laughed about it, but these are things that we work on together, right? A lot, and because we have a common goal, and that's to understand how intersectional stigma and HIV stigma work, and are not allowing Black women in the DC metro area to live their best lives, basically. Their inability to access services, again, that seem available. We have low rates of PrEP use, low antiretroviral adherence. So we wanted to get at some of the intersectional and then also some of the syndemic pieces around why that might be happening. So now I'm going to talk about a little bit about my work. I'm only going to talk about 2 studies. Yes. So this is study 1. This is not the name of the study, but this is what I'm calling it now. It's the cumulative score conundrum. So this is a paper that was on application of syndemic theory to Black men who have sex with men in the MATS, the multi-center AIDS cohort study. Most of us are familiar with that. So this was a paper that I wrote with my mentor, Steve Shoutouts, and of course, the hard hitters at Pitt, Ron Stahl, Amy Herrick, et cetera. I would Pitt him and Dyer. I think I was, I don't know where I was in terms of being married. I think I was still hanging on to the Penniman. This was in Journal of Urban Health, and it was published during the dark ages. And the reason why I say that is because we've come a long way as it pertains to syndemics, but I want to kind of show you where it all started for me. This was the first paper that was published on syndemics in Black MSM. So a little bit of background. So growing up as a Black man who has sex with men, MSM, in the United States of America confers dual minority. Here we go again with what looks like and sounds like intersectionality. And this is based upon both one's racial and sexual identities. There are multiple challenges to mental and physical health that exist for members of this sexual and racial minority, including but not limited to higher rates of HIV acquisition and mental health problems compared to either, again, heterosexual men or non-Black MSM, right? So these brothers, they're at their intersection of race and sexual identity. The developmental exposure to multiple minority stressors, so this is grounded in minority stress theory, okay, contributes synergistically to excess burden of a disease, and this is what we call a syndemic, okay? Syndemic theory had, at this time, been used successfully to explain HIV risk-taking behaviors among mostly white MSM in the United States and HIV prevalence and incidence among MSM in Thailand specifically. So the MAX is an ongoing prospective cohort study of the natural history of HIV infection among men and in the United States. I'll talk a little bit more about the methods. I'm not going to get into the meat, the bones about this, this particular paper, but I do want to show you how we analyze the data and why it's limited. So the theory posits that there's a constellation of health problems. We got depression, sexual compulsiveness, substance misuse, IPV, and stress. This paper, I think it's still, you know, it is a great paper because what we did was we looked at how these problems accrue across the lifespan, and each condition amplifies the negative impact of one or more of these health conditions. So this was the syndemic. For Black MSM who face multiple overlapping isms, negative health impacts correlate to being a dual minority. They might even be further exaggerated. So again, just being at that intersection is not good. It's not the intersection is busy, right? So while there's a limited but extremely influential body of research that examines the impact of dual minority status, few, as of that date, had done so utilizing well-validated retrospective measures. So this is what I did with the MAX. So my objective was to analyze data from a large-scale epidemiologic cohort study among MSM. The MAX, the multi-center, it's the oldest, literally, cohort study of gay men in the United States. The aim was to explore the extent to which syndemic relationships could be observed among Black MSM participants in the MAX. We hypothesized that multiple interconnections among psychosocial health conditions would be found. So a lot of times in syndemic studies, the first thing you do is, let's see if there's a syndemic. You don't just assume there is one, right? And whether that occurrence of negative early life events would be associated with syndemic production. So again, when we think about syndemics, it's not just like, oh, these are things that are happening. All right, cool. I feel like it's called syndemic production. Like something is happening, right? It's like this synergy that's occurring that's leading to negative poor health outcomes. The MAX is a prospective cohort study conducted in Baltimore, Chicago, LA, and Pittsburgh. So the original study had a sample of 6,972 men, followed since '84. Again, this is the beginning of the epidemic. Data are collected every 6 months. They have medical treatment, sexual and substance use behaviors, physical exam, and then collection of blood for lab testing and storage. I used the data from the MAX sub-study. So these were visits 49 and 50. The reason why, think about a sub-study now, you're like, oh, I want to add some more measures to the WISE data or to this other data set, right? And I'm interested in social position. They didn't ask these questions, and I want to ask these questions. So they ask additional questions around life course stuff, like the period of coming out, the period of youth in the past 5 years, et cetera. And then, of course, they ask questions about syndemics. Questionnaire is 30 to 45 minutes, and they receive $10 for their time. There's the sample selection. 87% opted to participate in the sub-study. This sample was 1551 surveys from unique individuals. Why there's only 301 Black men, I don't know, okay? But that's what it was. And originally, I remember this, Jamila might have been there. I originally was gonna do a disparities paper, and I was gonna compare Black and Latino MSM, and I got yelled at. It's okay. I got yelled at, and it was a life lesson. And I was told there's enough heterogeneity in the Black community in order to show that there's disparities. We don't have to be comparing ourselves to other folks. And I was like, but it wasn't quite put in that friendly of a thing. And I was like, but there are only 300 men. And it was like, we'll just go for it. And I did. And it was great, right? 300 people. So my outcome measures, I have to check my time, were depression measured by the CESD, dichotomized depressive, this should say depressive symptomatology, sorry, or depressive symptoms. Sexual compulsiveness was a 10-item scale. I'm not going to get into the whole scale thing situation. The paper has been published. Substance use, including binge drinking, at least weekly use of drugs, 6 or more drinks on one occasion. This was 6 or more at the time. I think it's 5 or more now for men. Intimate partner violence, stress, and then a syndemic. Okay, so this was like about 10 years ago, but it was 2 or more of the above in an individual. So I created a cumulative score and I dichotomized it. So 0 to 1 was no syndemic, greater than or equal to 2 was a syndemic. It was beautiful, but we know that that's a problem, right? If that's the definition, then everybody's got a syndemic. I got 2 or more things going on all the time. You know what I'm saying? I'm stressed, I'm this, right? And so we need to find some other ways and nuanced ways to really think about this, okay? And then we also think about the fact that we're talking about dual minority status. There are some people for whom that's just my life. I'm depressed and stressed all day long. It is what it is. I was born that way. My mom was stressed and pressed. Everything is happening. You want to call it syndemic, but it's really just how I roll. Like, this is my life, right? And so in certain populations, these things are prevalent, right? So we also want to think about that when we're modeling things and thinking about stuff. So those are the syndemic. These are just some basic results. Reported increase. So some of my outcomes were unprotected anal intercourse, receptive anal intercourse, physical abuse in early life stages. So don't forget, this was like a life course kind of thing. Childhood victimization in their early life stages, internalized homophobia during the period of coming out, discrimination, these are recent, in the past 5 years, internalized homophobia in the recent 5 years. So again, internalized homophobia maintained, this is something that was occurring not only when they were coming out, but in the past 5 years. And then less life satisfaction in the recent 5 years. So the way that it was dichotomized, 0, 1, no syndemic, 2 or more syndemic, the people in the 2 or more category reported more of these other conditions, right? That increase their risk for HIV, okay? So this last table, I try to get fancy. If it doesn't work, blame it on something else. So this table represents results of the 5 multivariable logistic regression models, showing independent associations of all of these 5. These are the syndemic factors: depression, sexual compulsiveness, substance abuse, partner violence, and stress. And so about as fancy as it got in these days, what we did was we constructed 5 different logistic regressions. And in each of the logistic regressions, we controlled for the covariates, of course. And we also controlled for that particular syndemic in the model. So you can see it almost looks like a correlation table where not included is the variable that I'm assessing is not included in the model, right? And so what this shows, okay, so yay. Okay, so it all did it at once. That's better than it skipping around. So most evident from this table is that each of the psychosocial health conditions is independently associated with at least one other psychosocial health outcome, which is in accordance with syndemic theory. So we have depression symptoms being independently associated with sexual compulsiveness and stress, et cetera, et cetera. Okay, we could see stress is independently associated with everything, except for substance use, which kind of threw us for a loop, but the data speak. You know, we don't speak for the data, they speak for themselves. So what this shows as well from these 5 different models are that these syndemic conditions are co-occurring. Stress is co-occurring with depression, sexual compulsiveness, and partner violence. IPV is co-occurring with substance use and stress, right? So again, it's not just, oh, you've got 5 of these things, right? It's that they're highly correlated with one another, right? If you are someone who is stressed, you have greater than 2 times, I'm just going to say it that way right now, the odds of also reporting or having scoring high in depressive symptoms, right? So again, we could see that these things co-occur. So what are some implications? Awesome, they explain the existence of co-occurring conditions in Black MSM. This study has important implications for future research agendas, public health practice, okay? So that's pretty general. Limitations, always some limitations. So while being useful in explaining the existence of co-occurring conditions, what this particular study did was fail to take into account the intersecting and interactional biopsychosocial relationship between the syndemic conditions. So a cumulative index, basically adding, this additive approach is neither multiplicative and more interactive, right? And they assume the following. They assume equal weighting of their effects on the outcome variable. Stress weighs the same as depression, right? Everything is pretty much the same, right? So they have equal weight in terms of variance in the outcome, right? And we know that that's not true. There is something to say about, no, I'm stressed, substance use, intimate partner violence, and depression. There's something to say that I have all 4 of these things. My life might not be as good as someone who only has 1. I mean, that's intuitive, right? But in terms of modeling, they assume equal weighting of their effects on the outcome variable. It also increases the likelihood of finding statistically significant effects because it reduces the number of covariates, right? So you're just kind of adding them up, right? You're saying, okay, like I said, 0 to 1, no syndemic, 2 or more, syndemic, binary variable, boom, it's easy, pop it in the model, it is what it is, right? But it's overly simplistic, not only in its analytic robustness, right? But also just in its ability to really tell us something about what's going on, right? So applying the concept of syndemic should employ multi-level approaches, okay? Another thing I want to point out is a lot of these were individual biopsychosocial. So they weren't talking about the environment. They weren't talking about other things that these men might have had to encounter in their period of coming out. Racism, discrimination, homophobia, okay? So applying the concept of syndemic should employ multi-level approaches, as well as examining what we're doing now, which are latent class membership, right? So we're going to construct these classes. And then also, this is a little ding, ding, ding for the qualitative research, also qualitative techniques, because, you know, we can ask questions and say, you know, can you fill out this survey and let me know how many times you experience this particular type of discrimination? It's a whole other thing to say, tell me about that experience. Right. And then you get people saying, I was walking down the street and blah, 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 this happened. And then in your mind, you're going, okay, he said, I felt that I was targeted because I'm Black and I'm gay, you know, kind of thing. That's different from check this box if you think the something, right? It's still not getting at the context. So again, qualitative techniques as well. This brings me to the second paper. It's latent profile analytic approaches to examining syndemics among Black men who have sex with men and Black men who have sex with men and women in the HIV Prevention Trials Network 061 study. So that's the name of the study. This was published in Sexually Transmitted Diseases. Last year, the past 2 years is just like one big old long thing. I don't know what day it is, it's too much. So this was 2020. So a little bit of background. STIs are important public health concerns, again, as we know, among Black men who have sex with men only, as well as those who have sex with both men and women. So Jamila might know a little bit about my background in this area. So HPTN, and I'll talk a little bit about it, was a study that enrolled Black MSM. I was interested in the bridging hypothesis of HIV among Black men and why rates are so high among Black women. Fell apart, but it was worth a shot. And so I was interested in MSMW, okay, men who have sex with men and women as well. Whether or not they identify as bisexual, they have sex with both men and women. Sexually transmitted infections also increase risk of acquiring HIV, which is also a critical concern. So we know that compared with BMSMO, this is the research that I'd actually done as a scholar. Research shows that men who have sex with men and women experience elevated levels of factors related to HIV, STI vulnerability. These things occur at the intrapersonal, interpersonal, and social structural levels. They may work independently that increase one's risk for engaging in high-risk behaviors, but often they work in a ding, 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 synergistic and reinforcing manner. That synergism and reinforcement and any combination of these factors is what's known as a syndemic, and these increase HIV and STI risk. Many studies of Black MSM treat BMSM as a monolithic group. This results in unintentional lack of distinction between the two groups of men. Aggregating both subpopulations of BMSM results in a lack of findings that are specific to men who have sex with men and women, and thus an absence of discussion related to this population. It's like the work we do now, and we lump Black transgender women in with Black MSM. And we're just like, well, that's what we're gonna do. You know, and it's like, my experiences are a lot different. And so somebody needs to do better, right? So despite the fact, MSMW occupy a position of epidemiologic importance, given elevated HIV risk and potential to transmit to both male and female partners. There are 5,988 words on this slide. I'm just gonna break it down real quick. So the HPTN studies illustrated, and these were the studies that I conducted, that MSMW experienced elevated levels of HIV, STI vulnerabilities, intrapersonally, depression and substance use, interpersonal, intimate partner violence, and trauma experiences, as well as racism and incarceration. Those factors work independently, but often work in a manner called a syndemic. We know what syndemic theory posits. Everybody knows if we had to take a test, everybody would get an A, because we know it's 2 or more vulnerability factors. Okay, this is the old antiquated Typhanye thinking that it's 2 or more. Understanding of syndemics and HIV among MSMW is limited. Okay, so we know the background. Singer, 1996, SABA Syndemic, right? Since then, the theoretical framework has been applied to elucidate disproportionately high levels of HIV risk behaviors. Extant literature supports that BMSM experience high levels of victimization. All well-documented HIV risk behaviors among men, including MSM. Okay, specific to MSM, the literature documents syndemics of depression, substance use, and violence. And these have been positively and additively, there's the word, ding, 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 additively associated with sexual risk behaviors. Okay. Another adverse experience that disproportionately affects Black people, but Black men in particular, is incarceration. Okay, HPTN happened to have measures of incarceration, and so we ran with it. We have an R01 that's called, I can't think of the name right now. Oh my God, it just left me right there, but it's on my last slide. And we're looking at incarceration and policing, okay. So Black MSMW often report elevated levels of compound interconnected factors, IHP and cocaine use. That corresponds with increased risk and frequency of potential exposure to HIV. Given the varied experiences of both subpopulations, syndemic profiles would likely vary between the group. That's the key word, profiles, right? So syndemic conceptualization. The cumulative index remains the most common methodology. They assume, however, that each factor has an equivalent impact on the outcomes. I just talked about that, right? Equal weight. And the number of factors represents some single unidimensional syndemic. So although it's intuitive, because of these assumptions, they don't completely represent complex interactions of various psychosocial and structural factors. There might be different combinations of factors, right? That differentially or have a distinct effect on HIV, STI outcomes, right? So this is what we do with the latent class analysis. Why LCA? LCAs emerge as a popular approach to syndemic analyses. Why? It simultaneously considers multiple factors that reveal grouping patterns emerging in the data. They allow for detection of unique combos. Should say combinations, I don't know why I did that. Not detectable using a cumulative index. Remember that thing, we're just adding them up. You got this, that, and that. You're not doing too good, right? This method also avoids some key analytic limitations of interaction terms. Okay, so we know that every time you add another term, it reduces your power. Again, here it is, limited power when several interaction terms are present, and substantial difficulty detecting interactions beyond pairwise. So you might have 3 or 4-way interactions, right? But if you're adding two interaction, and just one more term, that's all you're getting, the interaction between the exposure and this, the interaction between these two variables, right? Latent class analysis maintains utility even when measuring syndemics consisting of large numbers of factors. Latent profile analysis is analogous, but it's for continuous indicators, right? So this is an LPA. Conceptually, the influence of syndemics on subsequent STIs is not a direct association, more likely mediated through sexual risk behaviors. We use data from HPTN 061 to conduct the LPA to test for baseline syndemic of, and so some people say syndemic. So the interaction of all these things is asyndemic. Okay, syndemics is the theory. So we tested for a baseline syndemic of depression, racism, stimulant drug use, binge drinking, IPV, and incarceration, and its effect on 6-month sexual risk-taking as a mediator to 12-month incident STI. Okay, so HPTN also had bio data as well. Incident HIV was low, okay? That's why, that was my original outcome, but it didn't work. We hypothesized that there would be unique combinations of risk factors that form a syndemic, and that those would vary between the men who had sex with men and women and those who had sex with men and only. Specific latent profiles would be associated with sexual risk and subsequent HIV, STIs. This was my little model, it worked. This was an RO3 that was funded from NIDA. And as you can see, it was supposed to, aim 3 was to look at whether or not the syndemic has an impact on HIV outcomes. So I just changed that to STIs later. So HPTN 061 is a large multi-site longitudinal observational cohort study of MSM. The aim was to determine the feasibility and acceptability of an HIV prevention intervention in 6 cities. MSM were recruited using methods such as direct field-based research, engagement of key informants, so there's social network data with the study, et cetera. And eligibility criteria included self-identification as a man or being male at birth, so cisgender male, African-American, Caribbean Black, or multi-ethnic, and at least one self-reported instance of condomless anal sex with a man. Self-reported data were collected through CASI. There were lab data as well. The initial sample consisted of 1,553 participants. I included only those who were STI negative at baseline, who were there for all 3 study visits, and who were not missing STI data after imputation. So the final analytic sample was 799. Again, whittled away. So the syndemic factors were lifetime perceived racism. I don't get into the meat and bones about this because it takes a long time to really get into the measures. Lifetime incarceration, intimate partner violence, trauma, depression, stimulant drug use, and binge drinking. Okay. Remember, these are baseline syndemic. So this was in the past 6 months or ever, right? Have you ever spent one night in jail? It's a really poor measure of incarceration, trust me. Everybody's like, sure, you know, kind of thing, but a lot of the men reported that they were, and there was a high incident incarceration as well. Okay, I'm gonna try to speed it up some. These are my sexual risk behaviors: being drunk at last sexual intercourse, substance use at last sexual intercourse, transactional sex, condomless receptive anal intercourse, having 3 or more sexual partners, and this is my incident STI outcome. We don't have to get into the nucleic acid amplification test, et cetera, et cetera. We use 12-month STI status as our outcome. BSM and MSMW status were covariates. Okay. Age, income, and then also site. And all of these analyses were conducted in SAS, everyone's favorite. So we conducted an LPA stratified by BSMO and BSMW to identify baseline latent syndemic profiles. To determine the ideal number of profiles, we compared a 2, 3, 4, and 5 profile model. Model selection considered entropy. We did adjusted Volumental-Rubin likelihood ratio test and Bayesian information criteria, or BIC, okay, to assess model fit. And then we did a bunch of other things in terms of the best fit model. All analyses allow for correlated residuals to address local interdependence of profiles, et cetera, et cetera. Then I use the classify, analyze approach based on the greatest posterior probability of profile membership. Okay, so I'll tell you a little bit more then. I'm going to be done in about 4 minutes. So we use Cochrane-Armitage tests for trend and chi-square tests to assess differences in ordinal and binary syndemic conditions, and all kinds of other wonderful, beautiful things. Okay. STI infection status was also tested across latent profiles. So I'll just get to the tables. This is the fun part. And then we actually conducted regression analyses. Okay. We have 3 models, one with latent profiles only, a model adding terms for potential baseline confounders, and a model adding confounders and sexual risk behaviors as mediators. All models use the scale parameter to correct for overdispersion, and we use intercollinearity, looking for a VIF of less than 3. So there wasn't a lot of multicollinearity, excuse me. Okay. Results at 12 months, 3.9% of the sample tested positive for syphilis, 4.2% for chlamydia, 2.2% for gonorrhea. This tells a little bit more details about the method of testing, right? Rectal swab, urogenital chlamydia, as well as gonorrhea. Overall, 8.5% of the sample tested positive for any STI. So the next chart shows median baseline. Here it is. This table shows median baseline syndemic factors and 6-month sexual risk behaviors stratified by incident STI. So you can see BMSMO, and BMSMW. No incident STI, incident STI. Okay, so again, what it shows is that nearly 1/3 of the sample reported being drunk at last intercourse, having used drugs at last intercourse, and engaging in condomless receptive anal intercourse. More than half the sample had 3 or more sexual partners. There were no significant bivariate associations between syndemic components and incident STI, with the exception of greater median times incarcerated among BMSMO. Only condomless receptive anal intercourse was associated with greater incident STI. Okay, and you can see that that's highlighted in the bold, and you can see the p-values, etc. Righty. All latent profiles models demonstrated exceptionally high entropy. Okay, among BMSMO, 2 latent profile models were successfully fitted. Because there were no statistically significant improvements in model fit from 2 to 3 profile models, we used the 2 profile model for the BMSMO sample, and there was no significant difference in model fit between 2 to 3 and also 3 to 4. So we chose a 4 profile model. Okay, I'm sorry, we chose a 3 profile model for BMSMW. Okay, with those models, we used the 2 for BMSMO and 3 for BMSMW to create one single 5 model profile for all subsequent analysis. So here we have it. All latent variable models had extremely high entropy. You can see the 0.99. And this is the table basically showing what I just said, right? So you can see with BMSMO, 2 latent profile models were fit. For BMSMW, there was no significant improvement. So we used a 3 profile model. Okay. And from 2.3 and 2.3.4, we created one variable for the analysis. Here's our profiles. Profile 1 was characterized by the highest sexual risk and overall highest number of syndemic factors among BMSM, including perceived racism, incarceration, IPV, depression, and binge drinking. Profile 2 was characterized by low syndemic factors and low sexual risk in MSMO. Profile 3 reflected the highest sexual risk and highest syndemic BMSMW, highest number of incarcerations, depression, and binge drinking. Profile 4 had the low sexual risk behavior, but some moderately high syndemic factors, whereas profile 5 had the lowest syndemic factors among BMSMW, with the exception of high perceived racism. These tables are the beauty of all the beautiful things in the world. To the left, we have our median syndemic factors across latent profiles. This is with BMSM. So what we can see here, the latent profiles are associated with perceived racism, number of times incarcerated, stimulant use, IPV, depression, and binge drinking. This is using the Kruskal-Wallis test. So you can see the different color bars, right? And that lets you know if they don't look different across, then there's no significant difference, which is why you might be saying, well, what about depression, right? There was no significant difference across profiles. You see the blue bar doesn't change much, okay? And to the right here, we have the number of participants engaged in 6-month sexual risk behaviors and with 12-month STIs. We see latent profiles were associated with being drunk at last intercourse, using drugs at last intercourse, transactional sex, condomless receptive anal intercourse, and having more than 3 sex partners using a chi-square test with incident STI, okay? Using Yates correction. Finally, we've got our risk ratios of incident STI across profiles and mediation results. Profiles 1 and 2 had substantially higher STI risk in both unadjusted and adjusted models, with nearly 3 times the risk of STI in both models compared to profile 5. That is our reference group. Profile 3 had the highest syndemic BMSMW. They had significantly higher STI risk in unadjusted models, although this was heavily attenuated after adjusting for confounders. Nearly 15% of the increased risk of incident STI in profile 1 was significantly mediated through sexual risk behaviors, where nearly 20% of the increased risk in incident STI in profile 2 was significantly mediated through sexual risk behaviors. What does this mean? Confirmed our hypotheses, the current analysis highlights different syndemic profiles for both groups of men. For BMSMW with a high sexual risk profile, the syndemic factors that characterize this group are incarceration, depression, and binge drinking. These findings indicate that interventions tailored to the specific syndemic conditions characterizing high-risk profiles should be considered. So for example, for both groups of men, mental health interventions, right, needs to impact depression and binge drinking should be considered, as should policy around policing and incarceration. Whereas for BMSMO, partner violence and interventions to reduce IPV may be more important. Across all 5 profiles, BMSMO had substantially higher STI incidence compared with BMSMW. Both high and low risk profile BMSMO had 3 times the risk of STI compared to low syndemic BMSMW, right? So it's like, right? Basically, this suggests that STI risk reduction interventions should address sex while under the influence of alcohol, as well as providing support for men who might be involved in exchange sex. So see, with the profiles, we get differing levels and different group membership, right? And class membership. That really shows us where we should target our interventions and our efforts, okay? Okay, some, limitations. The study's limited to 6 US cities. We had a high risk sample, right? So it limits generalizability, the usual suspects that we know, okay? Might be spurious associations, social desirability bias, et cetera, okay? So what, right? What's next? What's next since you know so much? This is my slide. I have an R15 that's examining syndemics in Black cisgender and transgender women. Actually, I don't have it. It was scored 21. We'll see. An R01 focusing on psychosocial syndemics and intersectional stigma of social position, support, and cohesion in HIV and non-communicable diseases. This is the new thing. And then we just are submitting a grant looking at syndemics and HIV non-communicable diseases and engagement in the continuum of care for HIV and NCDs among sexual gender minorities in Abuja, Nigeria. Thank you, CFAR, for inviting me. Jamila, my sister in the struggle, thank you for thinking of just little old tiny old little old me. University of Maryland, PRC, HPTN 061, Black Caucus, Black Gay Research Group, my mentor, Steve Chopsall, my main man, City of Compton, yes, I'm that person. Delta Sigma Theta. Actually, at first I didn't have this, but one of my line sisters is a psychologist and she's actually on here, Meredith. So I'm glad I have this. So let everybody know I gave us a shout out. And to the R01, Stop and Frisk is the name of it. I couldn't remember it, is funded a lot of the incarceration work, our PRC, and then also my grant by NIDA. Thank you very much. That was long. I'm glad that you're still here. And with that, I am going to stop sharing my screen. Thank you so much. And I'm open for questions. Oh, thank you, Julia. Thank you, thank you, thank you, thank you. I know it was a whole lot. My students are like, she talks too fast. She talks too much. She talks too fast. I'm like, oh. Craig. See, I did right. See, I think the Black Caucus, Black Gay Research Group. Yes. Okay.
Yes, you did. Thank you very much.
Yes, I would not. There's no way. Yes. Thank you, everybody. Are there any questions? If there are not, well, I'm going to
question in the chat.
Thank you.
Sorry, do you want me to just read it? I was writing because
Oh my God. You know what? I am sitting here like I have never been on Zoom.
Well, it's long. I thought of the
insane.
question and then I thought, well, I'll write it down so I don't forget it. Thank you so much for.
I love non-sophisticated questions. Those are my favorite.
Well, I was thinking about this wonderful talk and very relevant to patient care, which is what I do, and the patients that I'm serving. And one thing I was thinking about is when this is less of an issue for syndemics because those are in existence and dynamically interacting with each other. But for intersectionality, which takes into account sort of your identity and then your experience in the culture around those factors. As culture shifts, and maybe I'm being too optimistic about how fast culture shifts, but in the last 10 years, there's been a pretty significant shift in some of our cultural perspectives around gender identity and sexual orientation. How does that factor into your research? I feel like I put in here, racism, there's stuff that feels very entrenched, but then there's other things that seem to be shifting rapidly. And so do you have a risk for sort of having some outcomes become outdated quickly when you try to study them? And how do you keep up with that and take that into account as you're analyzing? It takes a couple of years to do a study, and meanwhile, gay marriage has gone through, or something has dramatically shifted in my experience, in my intersectional experience.
Yeah, that's a really good question, and one that I can only say, like you just said, the research is things change so rapidly. I know that myself and a couple of colleagues of mine were always talking about how even some of the acronyms and things that we use are change rapidly, and I feel like I'm always behind. It's an unfortunate truth in that even by categorizing men as MSMW, MSMO, it reduces men to sex and their sexual partners. When it's just more dynamic than that. I'm not just who I have sex with, and et cetera. But one thing that I do, because as you might be able to tell, I don't necessarily belong to those communities, is I make sure I keep it simple. Like I just make sure, this is why I think the Black Gay Research Group and the Black Caucus, it's a group of community members, researchers, scientists, scholars of their own lives, a lot of PhDs, ain't got a whole bunch of letters behind their names, but they are experts in what's going on and keeping their feet to the ground and their ear to the ground as it pertains to what's going on in the community and what needs to happen in the community. And so a lot of times I just be real quiet and real quiet, and I just listen to them, and just, and if I have questions, always taking it back to the community. I don't know if it's even possible to stay ahead of it, which is what I think you're also alluding to a little bit. But and sometimes we do fall behind, but I do think there's a lot of credit, in given to people who just step back sometimes and say, as researchers, we're always trying to keep it going. I got to keep, where's the gap in the literature? I got to do it. I got to write the grant. I got to, and sometimes just slowing down. Maybe you didn't get 17 R01s last year, or didn't submit during each cycle. But sometimes it takes a lot of time to do community work and to engage people and find the stakeholders and say, what is the most pressing issue right now among Black, gay, and bisexual men? What is happening in the community? And as the culture shifts, gay marriage is, legal, right? As these things start to shift, what does that mean in terms of interpersonal relationships, right? I was talking to somebody last week, and we were talking about relationships, and I was saying, well, we're always talking about who's your primary partner. What about your romantic partnerships? That's like a heteronormative thing. Everybody's like, I don't have one main partner. I got a lot of main folks. You know, this person's main for this thing, this one's the thing for that. You know what I mean? And so thinking about what about other relationships that might be supportive or not? You know, just thinking outside of what we know to be the norm, right? And as you said, these things do shift. And I think a lot of times it's okay to admit vulnerability in that. I do it a lot, like I don't know. But tell me what it is that I need to know. And I'll do my best to represent the voice of the community. And then also bringing in people from the community to be on some of these grants and be scholars of their lives so that we are, you know, meeting the people where they are. I think it's hard as researchers because we do get caught up. And as a clinician, I you know, I don't envy you because you work, you know, one-on-one with people, and it's always this push to make sure that you're culturally sensitive and that you're culturally appropriate and that, you know, you're not saying the wrong thing and that you're not misnaming people or using incorrect pronouns and, you know, things of that nature. And it does shift. And I think sometimes just admitting that vulnerability goes a long way. I think people are more respectful of just saying, at least you asked, you know, instead of just assuming that what you learned last year is, or, you know, we're trying to do our CMEs and our CEUs and keep up with the thing. And the thing might change tomorrow. Intersectionality might be something, you know what I'm saying? And so we just want to kind of keep up with that because it is a social sort of construct and society changes and things change. And with that, our conceptualization of these things also has to change. That was a long way to say, I don't know. I try, I try my best. Yes, here we have it. Research changes rapidly, but people don't, some don't. Systems don't, more specifically. Systems don't, right? So that's a really good point. So while we're changing and changing, right? And that's an excellent point, Dr. Merchant. So while we're changing and the you know, things are changing and it feels dynamic, those systems, they're not changing. And to be honest, it's almost like the anti-Black racism thing. Like, what can we do? I'm like, I don't know what to tell you. You know, the intervention needs to be with the oppressor. You know, you can't tell the oppressed people how to deal with it better, right? So it's like the system is what needs to change. And so even though we, you know, the culture changes and we've got new names for things and stuff, and we have a new name for it, and we're not going to talk about social determinants, it's structural and political. If those things never change, we're going to be talking about the same thing forever, never, 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 amen, right? And so that's the part, that's where the impact comes in, right? The policy changes and being an ally and an advocate and things of that nature.
We do have one hand up.
Hi.
Hi, how are you?
I'm great.
We've been on the stigma working group with Florida cohort, like the shark study.
Yes.
Yeah, so I'm really glad that I got to be on this call and see your research.
Hi.
Hi. My question really herein lies is, what are your perspectives in like moving forward? You know, you brought up this great, not juxtaposition, but, and I wouldn't say great, but this juxtaposition between syndemics and intersectionality. My question is like moving forward, thinking in an intervention approach, how do we address both, you know, intersectionality and the power dynamics with intersectionality in society, in addition to syndemics?
That's a really good question. And so like I was saying, my colleague Vielka wrote this whole entire paper. What I'll do is I'll send them over to Kim. Maybe you can just email the people who were on this talk. Because I'm in a working group that with the same thing. We're like, what do we do? Is one more important? Is it better? Is it great? And so like I said, in maybe the third or fourth slide, I see syndemics as the what is going on, what's happening with these intersecting things, and then the intersectionality is why. So, or not just the why, and I don't think they're separate. It's like the what, the why. You know, I think they really inform one another, basically. I really feel, I'm gonna go back to what Dr. Merchant said. I really feel like as it pertains to intersectionality, these are the isms. There has to be the structural systemic change, right? So those are the interventions and the work that needs to be done. And that, you know, I'm a qualitative researcher, epidemiologist. I'm like, I do the numbers, I do the thing. But then there's also this thing like, so what are we gonna do? Now we know this, what are we gonna do? Now we wrote 15 papers, we have 55 data sets, we got 99 co-authors, 54 things, work groups. What are we doing? right? And so again, I always go back to like a research group and the Black Caucus, or that are part of HPTN, because that's what we do. So what you do is you have a seat at that table so that you can then say, I'm sick of seeing the same old people getting funded, the same old shebang bang. We need a protocol that's going to address the structural systems level oppressive stuff that is impacting people who sit at these intersecting social positions of race, class, sexual identity, sexual orientation, gender, and then also people who live in neighborhoods where there aren't any resources, you know, et cetera, et cetera. When I think about syndemics, I think about our interventions, right? And so we've got psychologists, psychotherapists, we've got epidemiologists, we've got behavioral interventions, bio-behavioral interventions. I think about PrEP, so you're taking the pill, and addressing those syndemic things that would help people engage in the care that we know they need to be engaged in. You know, what we need to do is get them to understand that does it work for you? Is this something that really works for you in your life? Right? We have the data. It's almost like us with the vaccines. Like we have the data, we know it works, blah, 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 blah. And then people are just like, I got other things to worry about. Right? And so what I really think it requires is interdisciplinary work, because it requires not only that systemic, oppressive, what are we going to do at that level? It's also like at the individual, interpersonal, we're talking about relationships among people. We're talking about partner violence. We're talking about community violence. We're talking about policing, all of these things. It seems like so much, it's overwhelming. It is. And what are we going to do about that is what we're going to do about that. And that's collaborate, I say, with people in the community, the stakeholders, the brothers and sisters out there who are fighting the fight, living the life, and collaborating. And we do this with community-based organizations, you know, but we do that when we need to write a grant and we need to do the thing. You know, we need to be out there in the streets, making sure that the things that we know are going to work are actually implemented at the community level. I mean, it can be as simple as, you know, just meeting the community where they are. You know, I know a lot of researchers are like, how do we find the people? I'm like, they're right there. You can't just go to the thing and expect people are going to talk to you. Imagine if somebody rang your doorbell and said, I want to talk to you. You'd be like, first of all, I don't answer my door. If I don't know you, don't be coming to my door because I'm scared, right? So I'm not going to do that. But also be involved in the community, right? Don't just go to the fair and the function so that you can collect data on people. You have to, you know, really, really care, right? And so I really feel like it takes multi-level approaches and multidisciplinary approaches. I do think that the science now is trying to find ways to intertwine syndemics and intersectionality, because I do think that they speak to one another. And the reason I say inter and multidisciplinary is because you have two people on both sides of things. And like I said, Thurka was just like syndemics. And I was like, when I see you, it's going to be me and you. And so it's always this, because she's a qualitative researcher. But I understand that, but I'm also like, there's something to this syndemic thing as well, where we've got these differential class membership that is putting people at greater risk. But they're also at greater risk because they're subject of these oppressive systems that consistently have its foot on the backs of marginalized populations, so where we can't move and we can't breathe. And until I can breathe, the syndemic gonna be there anyway. But until I can breathe, we can't even get there because I can't breathe, right? And so all of that needs to happen at once. And then one of the in SHARP is, I'm sorry, not SHARP, but SHARC is thinking about intersectional stigma, right? So a lot of that comes from these places of, you know, the power structure, looking down on people, just living their lives and going, oh, they're this, they're that, they're this. You know, I got HIV, I've got this, I've got that, I'm poor, I'm a person of color, and et cetera. And then you got people who are making decisions about your life and don't understand you culturally, right? And so all of these things need to happen at once. And I don't think it can be a stepped sort of thing. This is multi-dimensional, multi-level. And until then, I think we're gonna keep, you know, recreating the same old thing and reinventing the wheel or going around in circles and circles and circles. That might not even answer your question. I was just waxing
Oh,
poetic.
it did. Thank you so much.
I was
Nice
just
seeing
rapping.
you.
All right, my people. If there aren't any more questions, I want to thank you for your attendance. Thank you again, Dr. Stockman. When I get out there, I have to come see you. I was out there for something, and I'm gonna come to San Diego. Thank you for inviting me. I had a really fun time. I was nervous, but I had a really good time. I really like good questions, and I like to see people that I know on calls, and it makes me feel special and loved. So thank you very much.
Thank you.
Thank you.
You're more than
Have a
welcome,
great-
Dr. Dyer. Thank you so much for joining us today.
Yeah, thank you. I'm gonna say, look, have a great rest of your day. It's bedtime, it's nighttime, it's dinner. I got to feed these humans.
Dinner.
Yeah, and they act like they can't do anything. If I'm like, you don't have to feed yourself. One is 4 years old, so I don't think he knows how to feed himself. So with that, thank you. Thank you so much. Give little Miss O a hug for me. I know she's
I will.
and have a good day. Bye-bye.